Hello, everyone. Thank you for virtually joining me. My name is Alexandre White, and I'm an assistant professor in the sociology department and the Department of the History of Medicine at Johns Hopkins University and Johns Hopkins School of Medicine. I want to especially thank the organizers for putting together this terrific conference, especially the organizers at the University of Rwanda Medical School and Johns Hopkins School of Medicine. You've really done a terrific job, and thank you so much for inviting me. I've been asked to speak today on the topic of the introduction to decolonizing global health, a review of the history and the rise of global health. And as we embark on thinking through this topic, we should consider how the legacies of history affect and perpetuate themselves in our present. We should think about what the histories of global health are and how they have shaped what is a very large and heterogeneous field today, and what it means, first and foremost, to decolonize anything, let alone a field as large as global health. When we talk about decolonizing global health, I feel that we are often speaking about the process of changing a field that is not necessarily well understood, while also applying a process, decolonization, that is also, while trendy, has a long and significant history and wealth of scholarship, literature, and theory behind it. Today we'll discuss both, break them down, and provide both theoretical and historical substance to these two concepts that can often lose their meanings as casual buzzwords. In this talk, I wish first to address the existing issues that have prompted much of our discussion about decolonizing global health. In this section, I wish to discuss a few of the many areas of global health that we might say retain a colonial perspective or reflect colonial power dynamics. In the next section, I wish to break down what is actually colonization and decolonization, what they actually mean, what this entails, and the effects that they produce. This will go beyond just the application of political and economic and military might in the case of colonization, to examine how colonization transforms the ways in which knowledge is perceived, legitimized, and the sociological and phenomenological effects of colonial domination and how they operate. In the second half of this lecture, I will explore some moments from history that speak to the colonial roots of global health more broadly. And in the conclusions, I hope to suggest what I have presented today can or should be employed to both complicate our understandings of global health and what it means to decolonize it and some potential ways forward. The world of global health and the international organizations that are essential to it, such as the World Health Organization, the World Bank, and others, are funded by more powerful economic nations which are able to dictate global health agendas. This has been the case to some extent in managing infectious disease threats over the last 30 years, as well as in agenda setting in a wide variety of other areas. Most scholarship agrees that this increasing demand for policy coherence around the globe, especially thinking about the moment that we're in currently with COVID, in the management of epidemic threats, has been driven primarily by Western Europe and the United States. The drive to globalize disease responses from these powerful economic and political states to those of smaller influence led to pressure, and still leads to pressure on developing nations to adhere to international guidelines, increasing the responsibility for global health security. And we often think about the ways in which global health is a product largely of imbalanced power dynamics between powerful economic states imposing their views on others. But I think what's important for us to think about today, and this is a framework that we should sit with for the duration of this talk at least, is the ways in which the supposed economic and political might and superiority, quote unquote, of health regimes in the West not only harm the quote unquote developing nations that are meant to be the docile recipients of aid and support, but also directly affects the ways in which the West might hold itself and presume itself to be superior in the face of health threats, especially in the case of epidemics. This is incredibly obvious and evident today when we think about COVID-19, and especially from the perspective of the United States. Now, here's a quote from March 29th, in a rare moment of introspection from Donald Trump. I've been watching that for the last week on television, body bags all over in hallways. I've been watching them bring in trailer trucks, freezer trucks. There are freezer trucks because they can't handle the bodies. There are so many of them. This is essentially in my community in Queens, New York. I've seen things I've never seen before. I mean, I've seen them, but I've seen them on television in faraway lands. And in this moment, it was suggested that the crisis the world was witnessing playing out, in New York City was simply something that could not occur. It was unfathomable to believe that this could occur in this place and was not images taken from somewhere over there. And this recalls, I think, in many ways, the images of the West African Ebola epidemic that took place several years ago, where similarly the Western world looked on in horror at scenes of doctors in their negative pressure suits with much publicized, limited access to personal equipment, protective equipment, overworked, and at high risk for contracting the disease themselves. All of these images were perceived and portrayed as a ghastly reminder of the limited capacities of African health systems to care for its populations. In places far away from the epicenter of epidemic, we watched, in the United States, as well as victims of Ebola virus disease died lonely deaths far away from their loved ones, to be buried under intense sanitary controls without formal ceremonies carried out by their families. The prolonged epidemic was blamed on quote-unquote West African cultural practices and widespread ignorance of science, mistrust in doctors, and a host of other banal actions that outside of an epidemic were barely scrutinized, but under the harsh gaze of illness had now been unfairly pathologized as the markers of a backwards people and unhealthy behavior. Social distancing practices, isolation, quarantines, and curfews were seen as the scrambling needs and practices of a bygone epidemic order, wholly alien from the sanitized spaces of modern hospitals and cosmopolitan streets of American and European metropoles. These tropes of chaos, horror, and cultural incommensurability with modern medicine harken back to early 21st century discussions about South African presidents Thabo Mbeki and Jacob Zuma's HIV/AIDS denialism, and claims that the virus HIV could be prevented, or virus spread could be prevented by showering. Epidemics of these diseases, disproportionately having far greater effects outside the overdeveloped West than within, highlight the myth of the yawning gaps between the Western world and Western health systems and the rest of the world. And I think it's important to think about these moments of immense political and economic power of Western states in the context of global health against this novel moment of COVID-19, in which we're seeing those same states struggle so significantly with an epidemic threat that in many ways I think was perceived to be unfathomable by many politicians and the general public. But we can see the ways in which this, we could call it Western sense of superiority and vision, supersedes the needs of the rest of the world in a variety of different ways in other examples. For instance, in the area of non-communicable diseases. We can look to the domain of non-communicable disease, and the figures that I'm about to show you from a Lancet article by Bennett et al. In 2018, which highlight the probability of dying from a non-communicable disease around the world. This image here demonstrates a global heat map with the probability of dying from any NCD between birth and 80 years of age. As the colors get redder and darker, the probability increases. This is for women. For men, perhaps the disparities are even more stark across the world. As we see, the probabilities are often greater in nations that are considered quote-unquote developing. We recognize the urgent need for some sort of global response to non-communicable disease that takes these glaring disparities into account. However, dominant ways of teaching about non-communicable disease risk often focus on behavioral risk factors associated with NCDs in the West, such as smoking, obesity, and sedentary lifestyles. The framings and justifications for these sort of behavioral risk factors and the framing of them are drawn significantly from health studies, such as the framing of heart study that took place in Massachusetts and the Whitehall study from Britain. And these studies, these long-term longitudinal studies, which were based on very small, a rather small subset of largely white American and white British lower middle class and middle class populations in urban centers have been used historically as the benchmark by which to understand non-communicable diseases, their risk factors, and the threat they pose globally. While important, these assumptions about NCDs often leave out or ignore the ways that NCDs, especially in much of the world, and especially those afflicting the most impoverished, emerge in ways out of environmental as well as social and sometimes infectious factors that contribute to the global burden. Our framing, rooted in a European and North American understanding of disease, ignores the lived realities of billions around the world. Moreover, such perspectives can often paint complex systemic problems linked to unhealthy environments and weakened health systems as the problems of individual decision-making. This has been the subject of many people's work, including graduate student John Schaefer at Boston University, as well as the Lancet NCDI Poverty Commission. In other areas, such as vaccine production, we also see that countries with the greatest need of vaccines are often unable to drive the production of these necessary medicines. The World Health Organization estimates that Africa in particular represents 14% of the world's population, but accounts for less than 1% of the world's vaccine production. While global health efforts such as Gavi, the Vaccine Alliance, has allowed for the significant subsidizing of vaccines to Africa, the lack of control over price setting, supply, and access leave much of the continent and its health systems beholden to outside actors for necessary resources. In these very brief examples, we see some of the ways in which the global health agenda is being set, framed, and envisioned in spite of or on behalf of, but rarely by those who may be in most need of health interventions. But how is this linked to colonialism? What about this is particularly colonizing? How can we understand decolonization within these contexts? So let's go to the historical approach. So in those brief examples, we see some of the ways, as I said, that the global health agenda is being set by formerly colonizing powers and imperial actors. And these questions are very important that I raised earlier. And as an academic and scholar of colonialism, these are central to me. To understand how to decolonize a system of thought or a field of research requires a sophisticated engagement with what colonialism first and foremost is as a political and economic and knowledge phenomenon. That colonial and European imperialism was a world historical force is not up for debate. By the outbreak of the First World War, the rise of European imperial expansion had reached its zenith. European and American empires had consumed and occupied 90% of the world's landmass, with Britain governing 20% of the total globe and 25% of its population. One of the most important contributions to human knowledge in the 20th century was the formal intellectual and critical examination of empires as world historical forces that governed extraterritorially, and imperialism and colonialism as practices and systems of that governance. Prominent anti-colonial thinkers have shown that far from purely a system of governance alone, the enduring power of ideas rooted in the management of empire affect social hierarchies and racial categories, state formation, the production of rights, as well as the roots of liberal democracy and the civil sphere today. Forms of colonialism, be they trade-oriented through the establishment of ports on unequal relations, or via settler colonialism, which consists of total occupation of land and territory, produce entirely distinct patterns of relation between people, space, and environment. The process of colonial occupation mandated the creation of new borders, the instantiation of new legal systems and economic relations, categories of people, and the transformation of sovereignty. It also produced genocide, forcibly eradicating millions of indigenous people in the Americas, the Pacific, Asia, and Africa, as well as organizing the largest violent force movement in history, the transatlantic slave trade. Into this cauldron of new social relations were thrown the establishment of novel racial categories for the delineation of economic and social relationships relative to colonial authorities. At this point, it's important to think about colonization as a dialectical or relational concept. As colonialism sought to take resources, labor, and power from other regions of the world to enrich imperial metropoles in Europe and the United States, it did so by extracting these riches from these sites. Walter Rodney shows that we cannot truly think of the foundational rise of European capitalist supremacy around the world in the 19th and 20th century without the concomitant exploitation of Africa through slavery and colonialism. Rodney argues that the development of Europe cannot fundamentally be extracted from the underdevelopment of Africa. The logical framework is clear. When we look at the history of Europe, we also look at the history of Africa, the Caribbean, Latin America, South Asia, and everywhere that was at some point gripped by the empires of Europe. In histories of the states of Europe, we too often politely separate them from their colonial dominions, upon whom they were built and upon whom European concepts of selfhood, economy, capitalism, and governance were produced. George Orwell was a keen observer of this phenomenon and captures this quite magnificently in many of his works. Locating the centrality of colonial occupation and exploitation to the wealth of the British Empire, Orwell notes in 1939 that what we always forget is that the overwhelming bulk of the British proletariat does not live in Britain, but in Asia and Africa. The Martinican politician, poet, and one of the founders of the anti-colonial negritude movement, Aimé Césaire, also highlights this dialectic, that the dehumanization of the colonized is a double move that also dehumanizes the colonizer at the same time, such that the production of an oppressed colonial subject is not without the callous violence of that operation reflecting back upon the author of that violence, the colonizer themselves. Also foremost to the creation of Europe as a discrete and stable entity separate from other spaces in the world, is capable of only being understood as a totality through its dialectic relationship to Africa. Thus, while Europe underdeveloped Africa and made itself from an economic standpoint, it was also able to conceive of itself as Europe. The true cunning of colonial power lies not exclusively in its material domination, but its ability to hide the relations between imperial domains and the colonies which provide them wealth and labor. What makes the actions of colonization so totalizing is the transformation in worldview that it brings about for those under its control. Former uncolonized subjects suddenly are forced to confront a system in which their own personhood operates in relation to the colonized, altering power dynamics and meaning structures in all aspects of life. In the words of philosopher Robert C.J. Young, this consisted of the appropriation of territories and of land, of the institutionalization of racism, of the destruction of cultures, and the superimposition of other cultures. The power of the colonial state and their sovereignty over occupied space derive from a power-knowledge relationship, to quote Michel Foucault, which produces knowledge for the purpose of colonial rule. Colonial sovereignty derives its legitimacy from its authorship both to impose its own vision of its history and identity, as well as enforce relations of subjection upon colonial populations for the purposes of labor and economic exploitation. This practice is enforced through violence and the capacity to inflict it. Thinkers such as Edward Said and Frantz Fanon have shown that in order to make colonization an effective mode of domination, a variety of knowledge projects also had to occur to allow for extraterritorial sovereignty necessary for imperialism to work. The economic exploitation was also an exercise in knowledge production. These knowledge projects were total ones, including the natural sciences, medicine, history, archaeology, and social sciences, to place the rest of the world as the objects of study with a predominantly European, or at times American, Persian, and Ottoman viewpoint as the referent against which all others would be judged. It's at this point where we can discuss the role of medicine and health in this colonizing project. The role of medical knowledge, like the role of all sorts of knowledges, was rolled into the colonial project and used to further the aims of colonization. And when we think about the ways in which particular knowledge produced, perhaps, in the West and then applied wholesale to the rest of the world through global health interventions, or when knowledge is taken and extracted from post-colonial sites or spaces in the quote-unquote developing world and then used to produce vaccines, medicines, or knowledge that doesn't actually get reflected back or used to support those populations from which that knowledge was drawn, we see these dynamics of colonization and colonial knowledge reproducing themselves. Health, disease, and medicine became throughout the period of colonization a means to ascribe difference between Europe and the rest of the world, as well as between those of European descent and those who are not. In this way, we see how medical knowledge under colonial knowledge frameworks are used to suppress and also eliminate the voices of non-colonizers in the management and care of health. In the 19th century in particular, colonial perspectives and concerns came to shape how responses were attended to globally. The first voyages to West Africa by the Portuguese produced incredible death rates among colonial populations and a nascent understanding of their susceptibility to foreign spaces. Settlement in the region produced mortality of greater than 50% for the permanent settlers well into the 18th century. The forbidding diseases to those Europeans unaccustomed to the threats led to West Africa being known as the white man's grave for the particular threat disease posed to non-native persons. Diseases within colonial sites were also a powerful way by which Europeans and European space could be reconceived against colonial dominions. By the 1880s, malaria was seen as the most pervasive threat to Europeans across Africa. As colonial cities were built and rebuilt across Africa in the mid-19th century, the concern for what was known as medical topography became a lingering concern. Some areas of cities were considered safer and more healthy than others by virtue of elevation. Prior to the knowledge of the actual causes of malaria, other than it being spread by mosquito vector, regimes of territorial control and urban sanitary design were employed to control infectious diseases and protect the European from the sicknesses they found across the African continent. For much of colonized Africa, European health forces and systems aimed primarily to serve European interests, often at the expense of indigenous populations. Segregation of Europeans from indigenous communities was seen as a mode of keeping distance away from the colonizing population. Often the justification for this was not solely based on medical knowledge, but also cultural and racist arguments about the limited capacity of Africans across the continent to maintain hygiene. In British-controlled Nigeria, several scientists from the Liverpool School of Tropical Hygiene wrote in 1902 that native children were a particular concern and that the threat to the health of Europeans, were a particular concern and threat to the health of Europeans, and only segregation could afford protection to the colonizing population. In German-controlled Cameroon, it was noted by German hygiene authorities that the Douala people were, quote-unquote, racially incapable of practicing effective mosquito control. Most colonial sites in West Africa were initially designed to enforce segregation so as to prevent malarial spread, placing European settlements at higher altitudes than those of the local population, subjecting the local population to far greater interaction with mosquitoes than the Europeans. Similarly, missionary and colonial medical work that focused upon the health of colonized populations often sought cultural and social determinants for existing illnesses, reinforcing the belief that non-European populations were incapable of effective sanitation and hygiene without the aid of Europeans. Similarly, in Cape Town in 1901, an epidemic of bubonic plague became justification for imposing racial segregation through the forced removal of most of the city's black African population to a quarantine location. This practice would in many ways inform future forced removals and segregation efforts in pre-apartheid and apartheid South Africa. In Cape Town's response to plague in 1901, we see the concerns for European health, trade, and colonial enterprise intertwine. Prior to the outbreak of plague, the city did not have a state-mandated urban racial separation. And though racial inequalities and de facto segregation did exist, Cape Town was largely an outlier among other colonial cities. The Cape Town bubonic plague epidemic of 1901 was a formative event in which in the history of racial subjugation in South Africa, and the period is seen as a major transition to state-organized urban racial governance. On March 12, 1901, due to the fear of spread of plague from within the city's urban slums, the Cape government forcibly removed 6,000 black Africans under armed guard and transferred them to Uitvlugt, a temporary quarantine site that was later made into a permanent township known as Indabene. This event is historically unique, as this evacuation occurred without concern for actual infection or based upon exposure to the disease. Removal was solely conditional upon race and living situation. Though it was claimed that the segregated space of Uitvlugt was a temporary site, the Cape government deferred the decision to close the area until 1902, when legislation codified its permanent emplacement. All movement in or out of Uitvlugt, later known as Indabene, was prohibited without a pass, a bitter precursor of what was to come in the form of pass laws in apartheid South Africa. The Cape Town plague epidemic marks a pivotal moment in which medical practices calibrated with imperial concerns over the maintenance of health in white European populations to produce novel forms of racial governance that would later be concretized and reproduced across South Africa. These actions transformed the urban space of the city and produced a blueprint for the first state-monitored and regulated, racially delineated, enclosed residential space in South Africa, the first township. Likewise, through mosquito and eradication campaigns in the Americas, colonial interests in hygiene and sanitation supported colonial interests. The success of American colonial actors in eradicating mosquito-borne diseases from Panama during the Panama Canal excavation, as well as in American colonial sites such as Cuba and the Philippines, provided the justification for these approaches. Employing a primarily military sanitation regime, by which soldiers would drain standing water and distribute pesticides to eradicate the mosquito vectors of disease, American sanitary practices began to operate on the same or larger scale as European actions taken in Africa and Asia. Architects of malaria and yellow fever eradication campaigns, such as the American doctor William Gorgas, became significant health actors in global conversations around disease control. These strategies of disease control employed the same discourses that we've already discussed across much of Africa. Randall Packard, a professor in the history of medicine at Johns Hopkins, notes that these early disease eradication strategies imposed unilateral sanitation regimes that were aimed at protecting the health of colonial personnel while leaving broader public health concerns to missionaries and non-colonial actors. These practices took on a larger racial dimension as the architects of disease eradication saw themselves as critical to establishing permanent white settlement in tropical areas. Gorgas, noting in his book Sanitation in Panama, remarks on the last page that the discovery of the Americas was a great epoch in the history of the white man, and through large areas of fertile and healthy country open to his settlement. The demonstration made at Panama that he can live a healthy life in the tropics will be an equally important milestone in the history of the race, and will throw just as large an area of the Earth's surface open to man's settlement and very much more productive area. So these examples from histories of colonial medicine show us the devastating effects that public health interventions can produce when the perspectives of a prioritized and powerful few are held over that of the many. These examples of colonial medical violence not only demonstrate how medical knowledge can cause serious harm, especially in support of colonial and racist aims to further European control, but they also demonstrate the capacity of colonial knowledge to reproduce and create discrete populations to serve the interests of racial ideology and systems, and also operate in the wider service of other political and economic interests. Colonialism is not solely about who has the power to enact reforms, interventions, and controls, but also about the types of knowledges that these interventions reproduce or serve. The examples of colonial health interventions mentioned before operated through a particular colonial perspective that saw the interests of European imperialism to be the sole justification for action, while the health of those under colonial rule went, except in some cases of missionary work, largely unattended, or at least secondary to the primary objectives of colonial rule. So to conclude, I want to stress that when we think about decolonizing global health, we not only think about the economic and political powers at work, but also the knowledges and perspectives they represent. While powerful economic nations often dominate and set health objectives for the entire world, we must also think about the ways in which these approaches reinforce beliefs about the capacities of people living in formerly colonized sites to self-govern. While diversifying representation is important, unless the fundamental logics of superiority that emerged in the colonial period and continue to this day are challenged, decolonization cannot take place. We must also question the fundamental assumptions of the global health project when it comes to assigning and ascribing geographical differences to the world. Remember, as Amy Césaire and Walter Rodney teach us, the history of the growth of economic and political power in Europe could only emerge through the underdevelopment of Africa, India, and the colonized world through slavery, exploitation, and resource extraction. When we think about terms like developed and developing nation, let's put the histories of these terms in context to think differently about our basic assumptions. Finally, let's imagine truly what a decolonized global health might look like. I urge you all not to think of what a finished decolonized process might look like from the vantage point of today, but rather start the journey now and accept that a truly decolonized vision will emerge out of the work, not before it is started. There are no blueprints, and don't expect an endpoint that can be arrived at by checking objectives off a list. It's a long-term and ongoing struggle, but a deeply important and necessary one. It is accurate to say that lives are at stake in these debates, and we should push forward accordingly. Thank you very much.